in combined men and women, colorectal cancer falls within the first two most common cancers in Trinidad and Tobago.
Because some people is going to do this colon flush thing.
Some patients think that would help prevent colon cancer, but there's no data to support that at all.
So is it ever too early to screen for cancer? Hi, welcome to Medical Associates Health Check. My name is Dr. Laisha Selvaraja. I am the Clinical and Human Resources Administrator for Medical Associates. And this is my co-host.
I am Dr. Christopher Bristow. I am a specialist physician in internal medicine, and I am the founder and CEO of the Concierge Medical Clinic.
So together we are going to be bringing you bite-sized pieces of information and discussions with specialists, physicians and surgeons in the medical field.
Yeah, and it's our goal to bring complex medical issues and break it down into simple language for you to understand.
So this podcast or vodcast, Chris, what are we?
I feel it's both.
I feel it's both, right? It's brought to you by Medical Associates Hospital, and just a little bit about the hospital itself. It was founded in 1979, so this is 45 years that they've been in existence. It started as a small 12-bed facility, and it's just slowly expanded, and it's huge now, right?
Yeah, it's grown to a well-established institution now, and I think we are well accredited, right?
Yes,
you were part of that team.
I led the team for accreditation. We are the first hospital in the Caribbean to be accredited by TMOS, and we're very proud of it. What that basically means is that we are being held to quality of care that is basically in line with that of the first world.
So high standard, international level care.
Correct.
That is assured so that patients know that they get the best when they come to this institution.
It's patient-driven. Customer service is a top priority. The quality that we're offering should be comparable to something that they would get somewhere else in the world.
Nice. So we will be bringing on some physicians as well as surgeons who will be breaking down colorectal cancer. And then we will give you all some different perspectives to see how you get into treatment, how you get into screening, and break it down really for you to understand in the most basic language.
Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates' gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, #1 healthcare for the entire family.
Welcome back to the Medical Associates Health Check. And we're going to jump right back into it now. We have with us our gastroenterologist, Dr. Sanjeev Solomon, and our oncologist, Dr. Nazreen Beam. We are going to be talking about colorectal cancer. So we are here with these two experts, and they're going to break it down for us in simple language. So welcome, guys.
Thanks for having us.
Nice.
So let's start with explaining what colorectal cancer is, because I don't think anybody really understands what it is.
So colon cancer is cancer of your large intestines.
Right.
So the digestive system is made up of many parts, and basically it's responsible for processing of the food. And you can get cancer in every single part of the digestive system, but today we're going to focus specifically on the large intestines, which is comprised of two main parts, your colon and the rectum. And in terms of cancer treatment, it varies between those two areas.
Okay. And let's talk about signs and symptoms, because you have these right-sided cancers, left-sided cancers. What signs and symptoms are they expected to see?
So I think classically we're taught that patients with left-sided colon cancer, and just for context, the colon is this long tubular sort of organ that starts on the right side and then goes across the top side of your belly and then comes back down on the left side and then connects to the rectum, and then you pass out, you poop. So the left side of the colon is closer to the exit. And if you have a cancer there that's sort of squeezing or blocking the pipe, then those patients, they usually say that they have difficulty passing stool, they feel constipated. If the pipe is really, really thin and only allowing liquids to go through, some patients could actually talk about diarrhea. If you have bleeding on that side, because it's so close to the exit, you could have red blood coming from below. Whereas patients who have cancer on the right side, which is further from the exit, if they bleed, they could have a change in the color of the stool, or they could become anemic, which is where you have a low blood count. And then generally, if a patient has cancer, they can get loss of appetite, they can feel fatigued.
Yeah, tiredness is a common thing.
Weight loss is a major thing as well. So those were the major things.
Somehow in my luck, right, as a doctor too, I get the patients who's always throw the curveballs, right? And they tend to come with a random symptom. You ever see any random symptoms in your patients who have colorectal cancer?
Well, sometimes, in terms of treatment, we have screening for cancer, where we have patients who don't have any symptoms. And then you have symptoms that are related to the cancer itself. And sometimes you find that those patients might come for some other medical problem and then get a CT scan, for example, and then you pick up a colon cancer,
right,
which is separate from the symptoms that they would be having, just an incidental finding. Right. And as a matter of fact, we recently had a patient like that who had come in for another symptom and happened to get a CT scan.
Right.
And I'm not sure how she made it to see you.
Well, I think she had some area of thickening in that large bowel area.
Right.
Which again, I think she was young, but she that prompted a colonoscopy to further evaluate, because things like inflammatory bowel disease is another possibility in a younger patient. Okay. And then we ended up having a look and we said, well, this is not inflammation, this is actually a cancer.
Right.
And then we spurred on the further treatment options thereafter.
Yeah.
But, patients could have abdominal pain. It's typical. And that would not necessarily make you think that colon cancer, but those would be the patients where you could pick it up.
Is it ever too young to have a cancer? Because Chris, I think we might have seen two separate patients, but Chris saw a patient, and it happens to be the same age as mine, 28 years old. Both of them have presented with abdominal pain. I think his had intermittent bleeding, Chris. Yeah. And mine just had abdominal pain. So when they come through in A&E, we're going to see them, we're going to examine and send them for a CT scan, and the CT scan picked up a mass. So is it ever too early to screen for cancer?
So I think those patients fall into the special population category where they don't really follow into that average risk screening guideline, but they had symptoms. And absolutely, you have to know your body. If you have a persistent symptom of the abdominal pain or bleeding, you don't have to wait till you hit 45 to request certain tests. You need to see a doctor, and that needs to be evaluated properly. In the case of those two patients, you had a scan that showed something. And absolutely, if you need to do a diagnostic colonoscopy to figure out what's going on, you do it. And unfortunately, in those cases, it turned out to be cancer. So they just started on that cancer algorithm a bit earlier. It'd be important to find out if they had any pre-existing conditions that might have predisposed to that, like family history of colon cancer.
Or genetics.
Or inflammatory bowel disease in the background. But no, and I used to think that, if you're young and you haven't bleeding, you probably have hemorrhoids. But no, you have to check everyone.
Yeah, I was going to touch on that because we see a lot of people that are young and would have hemorrhoids, but how often are they going to you to really get a colonoscopy just to make sure? I don't think it's often
one
enough.
of the things that happens a lot is that for younger patients especially, because in oncology I've seen a lot of patients in their 20s being diagnosed with cancer, and I'm sure Dr. Solomon would also. A lot of these patients have repeated visits to their doctors complaining of bleeding. And I think the take-home message really is that you can't be too young to have a cancer. So if it is that, one, you have a symptom that's persistent over a prolonged period of time, or even as a doctor, you're seeing patients who have a symptom, you can't be too cautious. This treatment could be life-saving. So having a screening colonoscopy in a patient who does meet the criteria and warrants further investigation is definitely recommended.
Okay, thank you.
Sometimes you might have a patient that comes in and they have an advanced cancer and the CA is normal. So then they might be in disbelief.
So let's talk about what screening tools should be used.
Medical Associates Hospital is the only internationally accredited tertiary healthcare institution in the Caribbean for quality in medical care. Medical Associates gold standard for quality medical treatment, culture of safety for patients and visitors, care based on leading, evidence-based best practices and compliance with international standards make us the leader in private hospital care in the Caribbean. Medical Associates Hospital, number one healthcare for the entire family.
Okay, so guys, tell me, what are the statistics for colon cancer?
So we do have a limitation in terms of our local data, but generally what we see in our clinics would be that in women, breast cancers are number one, prostates are number one for men. But in combined men and women, colorectal cancer falls within the first two between lung and colorectal cancer, the two most common cancers in Trinidad and Tobago.
Okay, so with that in mind, should we be screening at an earlier age? What do you think we should be doing?
So if we can hit the mark of screening everyone at the age of 45, it'll be a good place to start. You know, when we have patients who are at a higher risk because of family history, genetic predisposition, etc., then we can aim for screening younger. But if we were only to meet the mark of screening everyone who is in the average risk at 45, I think we'll make a big difference in terms of our outcomes.
And the options are, you can either do a stool test every year,
Yeah,
or you get a colonoscopy.
either one.
That's bottom line.
Okay.
Colonoscopy. That's real important because, you know, some people just go and do this colon flush thing. But I think a colon flush is obia. What do you think?
I tend to agree with you. So gone are the days when you need to purge with Epsom salt and milk up magnesia every year for school holidays. I guess some patients think that doing a colon flush would help prevent colon cancer, but there's no data to support that at all. And I think there's a lot of that going around. It's quite expensive from what I understand, and really there's no benefit to doing it.
Is it dangerous?
There's a danger as well because you're putting in liquid and air under pressure, and there's probably a theoretical risk of bursting a hole through the side of your colon. So I wouldn't do that lightly, and I certainly wouldn't recommend that to patients.
Good. Because I mean, like you know, we talk about symptoms, having a symptom, but usually that will mean that whatever is inside the colon is already at a significant size to cause something.
Yeah, that is correct.
But if we have people who don't have any symptoms, right, that's what we'll say is asymptomatic, what do we do there? I mean, that's where screening will come in, right?
I think that's absolutely where screening comes in. So the purpose of screening is to pick up something before it has the chance to do something bad. And that's why you have these guidelines where you start screening at a certain age, because the statistics are showing that, you know, past that age, your chances of developing cancer are higher. So for colon cancer, that age we talk about is 45. For the average risk person, meaning that the person who has no symptoms, has no family history of colon cancer, they don't have inflammatory bowel disease. So ideally, once you cross 45, you should start thinking about screening for colon cancer.
Right, and that will be what? We could do a test your stool, we could do a scan, what we could do.
What about blood tests? Because that's a common question.
Right, so I know there's a lot of general practitioners and private doctors who do the blood tests for colon cancer, and that test is called the CEA test.
Yeah.
That really was never meant to diagnose colon cancer, but meant really to monitor someone who has already been diagnosed with cancer. So you do it at your baseline, and it's, 100 when it's supposed to be less than 5.
So what's the benefit? What's the benefit of doing the CEA for screening purposes?
So CEAs are not meant for screening. And as a matter of fact, you also have a certain subgroup of patients who do not secrete CEA as well.
Okay.
And so sometimes you might have a patient that comes in and they have an advanced cancer and the CEA is normal. So then they might be in disbelief, oh, do I really have cancer because my CEA is normal? But CEA is not a screening tool. The screening for colorectal cancers usually start with colonoscopies, and Dr. Solomon will talk some more about.
And stool tests. And just to complete that CEA discussion, I see the opposite side of it, where a patient has the normal value for CEA is between 0 and 5 in most labs, and a patient will come in with a CEA of 6. And then you can't get it out of their head that they think they have cancer.
Right.
And they're forced to have a colonoscopy now. And then they do the CA the following year after a negative colonoscopy, and then we're stuck in a cycle where we have to keep doing colonoscopies.
Okay.
So
And
it is
CAs
quite
are
dangerous.
a non-specific marker. So sometimes, like even bowel inflammation, sometimes smoking actually could cause your CEA to
really?
be elevated. We've seen it elevated in patients with lung cancers. So it isn't really a screening tool and shouldn't be used as a screening tool or a substitute for one.
Okay, so let's talk about what screening tools should be
Right.
used.
So what we should be doing is there are various tiers of recommended screening for colon cancer. And
Yeah.
according to the US guidelines, the first tier should be either a stool test to check for blood, something called a FIT test, which is a fecal immunochemical test, just basically looking for blood. And that should be done annually. And that is recommended. If the stool test is negative, you do another one next year, and then another one the following year. And every year once it's negative, then you're doing adequate screening. However, if the stool test is positive for blood, then you're obligated to do a colonoscopy.
Okay.
And of course, you can go straight to a colonoscopy as your screening modality.
And that's the gold standard,
That
right?
is the gold standard because that allows you to directly look at the colon. And if you see something, you can biopsy it, you can remove it if it's removable. If the colonoscopy is negative, then you're good for 10 years.
Okay.
So from the patient's perspective, I have a lot of patients who come in and they're absolutely petrified of a colonoscopy. And, I normally have to go through, it's not that bad.
Yeah, and a colonoscopy is not surgeon. It's not surgery. I'm not a surgeon. And what you do for a colonoscopy, just to run through it quickly, I think the worst part of it is the colon prep, where you have to sort of cleanse the colon or purge as you would in Trinidad. I got a purge when I was young. That's no longer recommended, by the way. So you have to do a colon purge. And what that requires is that you're on a clear liquid. If you're doing it tomorrow, you're on a clear liquid diet today, water, coconut water, clear fluids. And in the evening, you take a purge pack, which is a powder you mix with water and drink. And then the following morning, you take another purge pack, and it should just be clear water coming out in that 6 hours before you come for the colonoscopy.
I think you're right. That is probably one of the worst things.
It is brutal.
It's nauseating.
And once you get to the hospital, we put in a little IV access for you to get some medications to keep you comfortable during the procedure. We insert the camera, which is basically a flexible tube with a camera and a light at the tip. And then you work that all the way around the colon. You're looking for any signs of any polyps, any signs of cancer, anything that's bleeding, anything that looks abnormal. And you could take little biopsies, which are little, pinches of tissue that you put under a microscope. That is not painful. You have no pain fibers inside your colon. The whole procedure takes about 20 minutes. And you get a report, the biopsies come back in a week or two, and you have a discussion. And then someone drives you home because you're not supposed to be driving after the sedation. It really is not that complicated of a procedure. As I said, there's no surgery. You're back to normal within a couple hours, and you definitely could get back to work the following day.
Dr. Solomon, I like how you said before, that the best screening test a patient could do is the test you get them to actually do.
Absolutely.
Right? And just from hearing how the colonoscopy sounded, people could get scared, right?
Right.
And I think as physicians, we could focus a lot on getting to a diagnosis, but we need to handle these patients with a lot of empathy and a lot of care and really focus on the psychological side of managing a potential diagnosis of cancer.
Okay guys, today we're going to do an upper endoscopy for Mr. Jagasa, who's been having persistent abdominal pain and acid reflux for over a year. Let's go. Alright Mr. Jagasa, we're going to get started, okay? So here we are entering into the mouth. Here's the bottom of the food pipe. You see a white line, which is the division between the food pipe and the stomach. Here we see Mr. Jagasa has a bit of redness. That can be a sign of acid reflux. Now we're entering the stomach. We're just going to wash off some of the saliva so we can get a better look. So here we are entering the small intestine. This is called the duodenum. And this looks quite healthy. There are no signs of any ulceration, no polyps, no signs of cancer. The lining looks quite healthy. Now we're back in the stomach. This is called the incisura, which is a little fold in the stomach, and that is normal and healthy. Now we're flipping the camera back on itself to look at the top of the stomach. We're just looking at the food pipe from underneath here. And again, there's a bit of redness. Mr. Jagger might actually have something called a hiatal hernia, which is a little pocket at the bottom of the food pipe. This ordinarily does not require surgery unless it is very large or complicated, but it can increase the risk of acid reflux. And we'll measure for that in a minute. But otherwise, there are no obvious signs of any big mass, ulceration, cancer. So this is looking otherwise quite healthy. So we're just going to do a quick biopsy to check for any bacteria in Mr. Jagas's stomach that can contribute to abdominal discomfort. Okay, close. So what Anne-Marie is going to do is do something called a rapid urease test, where she takes the biopsies, puts it on a card to look for any signs of H. pylori bacteria. Here again, I'm looking at the bottom of the food pipe, just carefully inspecting for any signs of acid damage. There are no signs of any erosions or ulcerations. And we're done. If there were any signs of any abnormalities noticed, the next step would be to do further biopsies to put under the microscope and do further testing.
As a gastroenterologist and as an oncologist, how do you all navigate dealing with the actual mental side of the cancer diagnosis for your patients?
Right, so I think that's an important question because now we've moved past the screening and we're talking about what do you do when you pick up something. So if I see something that I clearly think is cancer, I try to have a candid discussion with that patient. I explain to them that there's a high likelihood that based on how this thing is looking, this is probably going to be colon cancer. But I explain to them also that to make a diagnosis of colon cancer, you need to have a piece of tissue under a microscope with the microscope doctor basically confirming that this is cancer. And that's one of the two pieces of information you really need when you have a new diagnosis of colon cancer. You need that diagnosis based on how it looks under the microscope. And the second piece of information you need is the staging, which is talking about if the cancer has spread. If the cancer is all in that one spot in the colon, sometimes even if it's in a polyp, I can remove it and cure the cancer. However, if that cancer is invading through the wall, getting into the organs on the other side, like the bladder, that would obviously mean that things are more advanced. And obviously, if there are little spots that have appeared in the liver and the lungs, that means it's advanced stage cancer, which is where you talk about like stage 4 cancer. When that happens, I sit with the patient, explain to them this is most likely cancer, but we need those pieces of information to make that next decision. Most patients are sad, but I explain to them that we just have to take this thing one thing at a time. And the next step is you need to speak to the medical oncologist, and that's where Dr. Bim comes in.
Right.
So when we have a patient with a new diagnosis of cancer, there are many factors that come into play to be able to determine how we're going to treat the patient. Cancer treatment is a combination of surgery, chemotherapy, and radiation therapy. For colon cancers, radiation is not involved. That's specific only to rectal cancers. So when we have the information, this is cancer, along with the stage, so we know whether the cancer is localized or metastatic, meaning that it has spread to another part of the body, then we can start making decisions in terms of the treatment. We sit together as a team, so Dr. Solomon, as well as myself, Dr. Capelday, who is one of our medical oncologists and the head of our oncology department in St. Joseph, the surgeon, as well as the doctors who look at the scans and the cancer under the microscope, the pathologist. So we sit together as a team, and then we decide what's best for this patient based on the location of the cancer and the stage of the cancer. So each patient might have a different pathway, even though they might have the same diagnosis as a relative or a neighbor. And that's important for patients to understand because the treatment is individualized based on the team discussion. We determine if a patient needs a surgery upfront or if it is that they will need chemotherapy or radiation therapy prior to having surgery.
So how do you decide which patient needs chemotherapy before surgery and who needs surgery before chemotherapy?
So as Dr. Solomon mentioned, sometimes when he might do a colonoscopy, he might pick up a cancer that's so early that that patient can have their cancer removed during the colonoscopy procedure and not even need a surgery. So that's the best case scenario. And that's why we advocate for screening, because we want to pick up patients who are diagnosed at that stage, because it means no major surgeries, it means no chemotherapy, no radiation. One of the things patients are also very concerned about is whether they'll have a bag. And having screening avoids all of that, because those cancers are picked up at a very early stage and the outcomes are excellent. In terms of more advanced stages, if the cancer has spread to other parts of the body, so typically I have patients walking in and they're asking, is this stage 4 cancer? So stage 4 cancer would be cancers that have spread to the lung or the liver. In some cases, for colorectal cancers, we're still in a position to cure stage 4 cancers. So a lot of patients think stage 4 is bad, but stage 4 is not always bad if we're in a situation where we can do localized treatment and cure that cancer anyway. Those patients typically would need treatment such as chemotherapy and radiation before we proceed to surgery. Because if we do surgery up front, then there's a high chance that the cancer could spread to other parts of the body before we even get to systemic treatment.
So surgery, we will get to surgery in another segment. But I mean, for you all, we're looking at the medical side of things. So there are for patients who have to go through this process, there are some worries or apprehensions that they may come with. I mean, I personally have dealt with relatives who've had colon cancer and even breast cancer. And when they go through chemo and stuff like that, they know their hair will fall out, they might change their skin color, their nails has changed color, right? How you prepare your patients when you're going to start these treatments, and letting them know what to expect. And also, what can their other parts or the other people in their care team, for example, their general practitioners, how can they play a role in, making that treatment process easier?
Okay. So the good news for most patients who have colorectal cancer, you don't lose your hair. So when we do initial treatment, baseline treatment, that chemotherapy that we give might cause a little hair thinning, but it doesn't actually cause you to lose hair. Right. Yes, some patients might just have a change in complexion, darkening of the hands or the feet, but generally that chemo is a much milder chemo than the chemo that might be given for other sites in the body. Right. And in some cases, a tablet-only form of chemotherapy can be used, so patients don't even need to have a drip. So, it's much different from the type of treatment for other cancers. But when we're starting to talk about cancer, we're talking about life-saving treatment. And in the grand picture, our objective as doctors would be to cure that cancer. So yes, there would be side effects related to those treatments, but I always encourage my patients to have the end goal in mind. And the end goal is that we're doing this treatment with the intention of curing or getting rid of this cancer. Even in the cases where we can't cure the cancer, then the treatment is intended to control symptoms and prolong life. And for most patients, that aligns with their objectives as well.
So Dr. Solomon, let me pull you back in. If we treat this cancer, and you want to check and see how, make sure this patient stays well. Yeah. What are the post-treatment or the post-intervention follow-up that somebody like that would have?
Very good question. So if I remove the cancer with the endoscope, then I usually bring them back in 6 months to look at that same area, which sometimes I could leave a little tattoo spot inside the colon and look carefully, make sure that nothing is coming back. But if they end up getting surgery, and the aim is to get a cure because you've cut out the cancer now, ordinarily the guidelines suggest you come back in a year. And here you're looking to make sure that there's no cancer that's come back where they join back up the colon, and definitely no signs of cancer anywhere else in the colon. And then usually we space out thereafter. You do a year again and then 3 years, and you never do it for a larger interval than 5 years. Various different guidelines have different screening intervals, but that's generally how you do it. You do frequent checks to make sure that you're still in the green.
Okay, so thank you very much. So to recap, today we talked about what colorectal cancer is, common signs and symptoms, the importance of screening. I think that's the biggest thing I took away from our discussion, and what treatment options are available. And it was really nice to know, Dr. Bim, that side effects are not as bad as everyone commonly thinks they're going to be. But I really appreciate the two of you coming on today. The next time we'll be talking to Dr. Yadish Singh, who is our laparoscopic cancer surgeon, and he will be delving into the intricacies of surgery in colon cancer.